I would like to invite Dr. Dhrushi Patel. Dr. Dhrushi has keen interest in musculoskeletal imaging. She also has keen interest in prostate as well as brachial plexus imaging. She is one of the chief consultants at Gujarat Imaging and Samved Hospital. I would like to invite her on the dais.
Thank you for having me here. Now I'm going to talk on imaging modalities for evaluation of tennis elbow. So tennis elbow is an overuse syndrome wherein which involves the common extensor tendon, predominantly the ECRB. Patient typically presents with a lateral elbow pain. There is tenderness and swelling, and this is increased when they grasp objects during wrist extension with resistance, like in racket sports or repetitive activities that occurs with certain occupations like painters. So the anatomy at the lateral elbow is there is a common extensor tendon origin, and below that there are the lateral collateral ligament complex insertion. The common extensor tendons are that originate at the lateral epicondyle. There is the extensor carpi radialis longus, which is above the common extensor tendon origin. The first tendon here is the ECRB, and then there is the extensor digitorum, and lastly it's the ECU. Beneath that there is the ligament complex, which provides stability to the lateral elbow joint. So whenever there is repetitive stress and overuse, there is common extensor tendinosis. Tendinosis meaning there is inflammation or edematous changes at the common extensor tendon. Later on, eventually there will be micro tearing and progressive degeneration due to immature reparative response, which will eventually result into full thickness tendon tear. So these are the continuum of findings that we see on the imaging modalities. So the primary role of imaging, it's a clinical diagnosis. The role of imaging is to exclude other causes of lateral elbow pain or underlying ligamentous injury, if any, especially in patients in whom the conservative treatment has failed. Radiographs, therefore, would be helpful to exclude the other pathologies. USG has its advantage of providing a dynamic evaluation, and there is scope for interventions, and MR is the gold standard. A typical radiograph, usually it is normal, but sometimes there may be a small calcific speck adjacent to the lateral epicondyle within the common extensor tendon. This is because of the calcific tendinopathy or enthesopathy, which can be seen in 25% of the patients of lateral epicondylitis or tennis elbow. Ultrasound is a very good investigation for evaluation of lateral epicondylitis, and where longitudinal plane evaluation is done, and we can see that this is a typical image showing the common extensor tendon. This is the lateral epicondyle and its slope. This hyperechoic structure is the common extensor tendon. This is the radiocapitellar joint, and this is the radial head. So this is the site that we are evaluating whenever we are doing an ultrasound for evaluating the edematous changes. Findings in tennis elbow involves having edematous changes or hypoechoic changes in the common extensor tendons, and when a Doppler is placed, there will be increased vascularity at this site. These are typical features of common extensor tendinosis. On MR, the structures are better visualized right from the outside the common extensor tendon to the ligament complex underneath and the bones. So this is how on MR these things look like. So this is a typical common extensor tendon origin, wherein the anterior tendon is the extensor carpi radialis brevis, which is the first to tear, and then there is the digitorum. The underneath is the ligament complex, that is the radial collateral ligament, which the posterior component is the lateral ulnar collateral ligament that inserts into the ulna, and these are the extensor tendons and their myotendinous junction. This is a typical coronal image which helps identify common extensor tendinosis, wherein this is the common extensor tendon and underlying ligament on coronal images. So initially, when the patient has lateral elbow pain due to lateral epicondylitis, they will have only subtle edematous changes involving the common extensor tendon, and this is tendinosis. The ligaments are normal. There is an MR classification to identify the continuum of findings from tendinosis towards partial thickness tear towards full thickness tear, and that can be identified on MRI. This is in another case wherein the 66-year-old female. Now you can see that here there are fluid intensity signal at the common extensor tendon, and that represents a tear. These are the coronal MR images showing greater than 50% thickness of the common extensor tendon tear, and with the intact underlying ligaments, though they are showing some amount of thickening and edematous changes due to the stress. Another case of tennis elbow where there is changes of tear within the common extensor tendon, which you can appreciate on all the planes. Besides that, on T1 weighted image, it had some dark area inside which represented calcification that suggests a chronic process. And lastly, this was a 68-year-old female with elbow pain. She had past history of steroid injections. Here there is a full thickness tear. You can identify that there are no structures in this region. It's the ligament as well as the common extensor tendon that is torn. And the role of imaging is to identify and exclude the other differential diagnosis, like presence of a radial head fracture, which will also present as a lateral elbow pain, but there is history of trauma, and X-rays and other modalities are helpful to identify this. When there is history of trauma, presence of instability, it can be due to the underlying ligament tear with the common extensor tendon being intact. Here there is the RCL tear. And as you can see that the retracted tendon end is here, and on CT there is an avulsion fragment, bone fragment that is retracted. This is another one with a chronic lateral elbow pain and history of trauma, where you can see that there is osteochondral lesion with edematous changes responsible for the pain. A volleyballer with a lucent lesion at the epicondyle at the capitellum, and which was an unstable osteochondral lesion responsible for the lateral elbow pain. And lastly, radial tunnel syndrome, which can clinically mimic tennis elbow, but if you see the site of pain is different. The tennis elbow pain is at the lateral epicondyle, whereas this is a little more distally, and wherein the nerve, as it passes underneath the longitudinal septum beneath the supinator muscle, it will be entrapped and will cause the lateral pain, and wherein there will be denervation changes in the supinator muscle, which is supplied by that particular nerve. So that is radial tunnel syndrome. To summarize, it's important to know the anatomy to understand the continuum of findings that happen from tendinosis towards tear. The ultrasound and MR appearances of tendinosis and tear are different, where tendinosis is just thickening and tear is where there is a fluid gap, which can be identified on the respective modalities, and the differential diagnosis for excluding other causes of lateral elbow pain. Thank you.
Thank you, Dr. Dhrushi, for such an informative session. I would like to invite Dr. Dimple along with Nisha Vyas to felicitate Dr. Dhrushi Patel.